Good morning everyone. Today the topic is post anesthesia recovery, and I am Dr. Sukanya from Department of Anesthesiology. So the SLOs, that is specific learning objectives, will be what are the standards for post anesthesia care, what are the parameters we monitor, and what are the complications we come across, and how do we manage those complications in the PACU, and what are the discharge criteria from the PACU. So we will look into all these. So the post anesthesia recovery, which is also called the post anesthesia care unit, it's actually designed and staffed to monitor and care for patients who are recovering from the immediate physiological effects of anesthesia and surgery. So when patients come to a PACU, they can be stable or unstable. So sometimes we may even have to resuscitate the patients so that we can stabilize them. And where should a PACU be located? It should be located near the operation theatre, and so that we can get immediate help, so that we have people to take, if there is an emergency, we can get access to the physicians. And the American Society of Anesthesiologists has set some standards for the post anesthesia care unit. So all the patients who have received general anesthesia, regional anesthesia, or had undergone surgery with monitored anesthesia care will be taken care of in the PACU, and patient has to be transported to the PACU by the anesthesia care team who have taken care of the patient in the operation theatre, and they will hand over the patient to a responsible PACU nurse. And the patient will be continuously evaluated in the PACU, and after a physician looks into that the patient is ready for discharge, the patient will be discharged from the PACU. And the first thing what we do is how we transport. So transporting is very important from the PACU. First we have to continuously monitor the patient's airway. If a patient has undergone surgery under general anesthesia, maybe a patient is obese, a patient is old or sedated, the patient may require supplemental oxygen. Now usually the staff of PACU are trained, so so that they can promptly recognize the complications. And once the patient arrives in the PACU, the anesthesiologist or the anesthesia care team usually hands over the patient and gives a detailed history, explains the medical condition, tells what anesthesia the procedure was done under, and tells what surgery was done, and hands over the patient to the PACU staff. And what are the monitors which are attached are, we use pulse oximetry for monitoring the ventilation. We look at the breathing frequency, the patency of airway, and capnography if the patient is connected to the ventilator. And for circulation, we look into the blood pressure, heart rate, and the ECG. And the vitals are recorded continuously, and at least it should be recorded every 15 minutes. And what are the recommendations for assessment and monitoring in the PACU? So all the systems have to be monitored. So the cardiovascular system, respiratory system, neuromuscular system, the mental status of the patient, temperature, pain, nausea and vomiting, and what is the status of the urine output, and drain and bleeding, everything is monitored in the PACU. And we can come across multiple complications in the PACU, like arterial hypoxemia, hemodynamic instability, all other cardiovascular problems like MI, arrhythmias, renal problems, and two main complications which we come across is post-operative shivering and post-operative nausea vomiting. And then regarding central nervous system, we have delirium, emergence excitement, delayed awakening. Then arterial hypoxemia is nothing but there is a decrease in partial pressure of oxygen. So if patient has less oxygen, you have to give oxygen. And one of the causes for arterial hypoxemia is upper airway obstruction. So what are the causes of upper airway obstruction? There may be loss of the pharyngeal muscle tone. There may be, if patient was the surgery was done under general anesthesia, there may be residual neuromuscular blockade, there may be laryngospasm. There may be airway edema, hematoma, or patient may have a obstructive sleep apnea. So there are two equipments used to maintain the upper airway. One is a nasopharyngeal airway, one is a oropharyngeal airway. So oropharyngeal airway is also called the Goodell's airway, and the idea of using a airway is to keep the upper airway patent. That is done by preventing tongue fall. So multiple sizes are available, and we can measure the size of the oropharyngeal airway simply by keeping the airway, measuring it from the angle of mouth to the angle of mandible. And how we insert the airways? First, as you see in the first picture, the airway is made to touch the hard palate, and it's turned 180 degrees to be placed over the tongue. And nasopharyngeal airways are also available, and patient who has a gag reflex, we can use a nasopharyngeal airway. And one of the contraindications for nasopharyngeal airways, if there is a skull base fracture, you should avoid a nasopharyngeal airway. And how we measure the size of a nasopharyngeal airways from the ala of the nose to the tragus of the ear. And regarding the factors, the multiple factors which can contribute to postoperative arterial hypoxemia. So we have to, if a patient has a saturation fall, we have to rule out multiple conditions. It may be cardiovascular, it may be respiratory, it can be GI, it can be related to infections, transfusion. So the main cause which we usually come across is maybe a pulmonary edema, or there may be a pulmonary embolus, or then even residual neuromuscular blockade, or there may be factors which can prolong neuromuscular blockade. So all those factors also have to be ruled out. There may be drugs, metabolic or physiological states, or there may be decreased level of hormones in if there is extremes of age, then other hormonal changes may be present, or if the activity of the depolarizing blockade is inhibited. Then how we give oxygen? Oxygen can be given through multiple oxygen delivery devices. So so if a patient is intubated, we use an endotracheal tube, and other oxygen delivery devices are nasal cannula, a simple face mask, face stent, venturi mask, a non-rebreathing mask where we can give up to 95% of oxygen with a 10 to 15 liter per minute of flow. And during COVID especially, we used a device called HFNC, that is high flow nasal cannula. And if you can manage the patient, oxygenate the patient by not using endotracheal tube, we can just go for a BiPAP machine, where we can give a EPAP and IPAP. EPAP is expiratory partial pressure, and IPAP is a inspiratory pressure. And other, apart from hypoxemia, there may be other hemodynamic instabilities in PSU. The BP may go up or down, and there may be a MI, or there may be cardiac arrhythmias. So there are multiple causes for, if a patient has hypertension, then we have to rule out multiple causes. The patient may be already a hypertensive, arterial hypoxemia may be present, hypervolemia, emergence excitement, simple shivering can cause hypertension, patient may have pain, patient may be agitated, may be urinary retention or bowel distension. So all these causes has to be ruled out. And if a patient has hypotension in PSU, then there may be an intravascular volume depletion. So we may have to give fluids. There may be increased capillary permeability. So we have to treat that accordingly. And if there may be a decreased cardiac output, or there may be a decreased vascular tone. So we have to recognize the cause and treat the cause. And if patient develops a myocardial ischemia, which is one of the common causes in PSU, patient may have complaints, there may be ECG changes, there may be hypotension, tachycardia, bradycardia. So we do a cardiac enzymes, a tropi, and then we have to get an expert consultation to manage the patient. Then multiple arrhythmias are also seen in the PSU, tachyarrhythmias, bradyarrhythmias, atrial fibrillations. And another cause of renal cause which is seen in the PACU is postoperative oliguria. So we have to rule out pre-renal, renal and post-renal causes. So pre-renal causes may be simply a hypovolemia, and renal causes there may be ischemia. So all these causes have to be ruled out. And post-renal, if there is an obstruction of the ureter, or there may be even mechanical, simple obstruction of urinary catheter also can cause a postoperative oliguria. And as I already told, postoperative shivering and postoperative nausea, vomiting are two very common things we see in PACU. So we have to, once patient develops, patient may be under spinal or general anesthesia. Main cause is vasodilatation, and we usually manage with tramadol and ondansetron. And some opioids are also used, like fentanyl. And postoperative nausea, vomiting, the cause has to be identified. The cause may be even the type of surgery, like a breast surgery or a vaginal surgery can cause postoperative nausea, vomiting. So we can give ondansetron before half an hour before the finishing of the procedure. A simple hypotension can also cause postoperative nausea, vomiting, because the blood supply is decreased to the vomiting center. And multiple agents, but we usually use ondansetron, which is a 5-HT3 antagonist. We give 5 milligram intravenously, and the another agent which we use is metoclopramide. Maintaining of blood pressure is very important so that we can prevent postoperative nausea, vomiting. And another complication PACU is emergency excitement, usually seen in children more, and maybe because of rapid recovery, a simple postoperative pain or a patient was already anxious preoperatively can cause a emergency excitement. And if we see delayed awakening, then again we have to rule out all the causes. One of the causes may be residual sedation, hypothermia, hypoglycemia, raised intracranial tension, and usually we have drugs like antidotes like naloxone, flumazenil, and neostigmine for neuromuscular blockade. And when should you send the patient out of the PACU? That is, when will you discharge? So we have multiple scoring systems to tell that when to discharge a patient from PACU. So mainly what we see is patient is conscious oriented, obeying commands, he is not having pain or having minimal pain which is tolerable, patient is not having any postoperative nausea, vomiting or shivering, and there is a responsible adult who can take care of the patient when we send the patient, especially for outpatients. So I'll just describe two scoring discharge scores. One is a modified Aldrich score. If the score is 9 or above, then we can discharge the patient. So what all parameters we look into is the activity, breathing, circulation, consciousness, and oxygen saturation. So the score is given like 2, 1, 0. So 2 is the best score, 0 is the minimum score. And as I told, if the score is 9 or above, we can discharge the patient. So we have, just look into activity, patient is able to move 4 extremities on command, you give a score of 2. And patient is able to move 2 extremities on command, 1, and if cannot move any extremities, it's 0. And coming to breathing, is able to breathe deeply and cough freely, 2, dyspnea 1, and apnea 0. And circulation, if the BP is within 20% of the pre-anesthetic level, it's 2, and if it is between 20 to 49%, it is 1, and if it is less than to 50%, it is 0. And if patient is fully awake, you give a score of 2. If it is arousable, 1, and if not responding, 0. And oxygen saturation, if patient is breathing in room air with a saturation of more than 92%, it is 2. And if patient needs supplemental oxygen to maintain saturation above 90, it is 1. And patient even with oxygen, if the saturation is less than 90, it is 0. So if the score is 9 or above, we can discharge the patient from the PACU. And one more scoring system, this is usually, this is a PADSS scoring system, where this is for discharging the patient to home with a responsible adult. So we have Again, the same thing applies to this. If the score is 9 or above, we can send the patient home. Here, what we look into is the vital signs, the activity level of the patient, nausea, vomiting, and pain. So, patient is having pain, it's 2. If not having pain, the score is 1. Nausea, vomiting, minimal or no vomiting 2, moderate 1, and severe 0. So, if a patient is having severe nausea, vomiting, we should not discharge the patient. And if the patient is not able to ambulate, we should not discharge the patient. So, basically it's a scoring system. So, once we put a score, we calculate if it is 9 or above, we can discharge. This is more of a surgical scoring system. Actually, there is one more which tells bleeding. So, if there is a drain present, then we will not discharge the patient. So, this is more of a surgical scoring system. Thank you.